Good morning, everyone. So we're going to ask the first speaker to come up to the stage. I'm Dr. Kathy Van Leeuwen. You guys all know Dr. Ron Hirschl. And we'll be presenting a couple of the tributes a little bit later. And also, one of our award winners from last year is going to be giving an update on his research. Please remember during the question session, or if you're coming up to the mics, to give us your name and your institution for the video. Thank you. So our first speaker is Dr. John Riley, and he'll be talking about extending the window of tolerance. Regulatory T cells permit late gestation in utero hematopoietic cell transplantation.
Good morning. In utero hematopoietic cell transplantation, or IUHCT, is an experimental treatment for inherited disorders of the blood. This includes sickle cell disease and beta thalassemia. Now, IUHCT has proven efficacy in a number of preclinical models, including the sheep, mouse, and dog. In clinical translation, however, the results have been, to this point, disappointing. A contributing cause to this is the relatively early acquisition of immunocompetence in the human fetus as compared to that of the dog, sheep, or mouse, such that the window of tolerance for IUHCT occurs at approximately 12 to 14 weeks gestation, much earlier in gestation than in our preclinical models relative to conception and birth. This is problematic for two reasons. The first is technical. The ideal injection sites for IUHCT are the umbilical vein and the fetal heart, both of which are minuscule at this early gestational age, although do grow, of course, as gestation progresses. And the second one is a practical concern. If the procedure has to be done by 14 weeks gestation, this, by necessity, excludes all fetuses receiving a treatable diagnosis after this point in time. The purpose of our study was to try to address some of these problems by asking two questions. First, what defines this window of tolerance for IUHCT, immunologically speaking? And second, can we use regulatory T cells, or Tregs, to extend it to a later point in gestation? So how did we study this? If you remember back to your basic immunology, you know that immature T cells are negative for CD4 and CD8. However, after maturation in the thymus, they express one of these two markers, and this is very easy to detect in the peripheral blood using flow cytometry. Now, we suspected that the transition point from the window being open to close might occur between gestational days 19 and 21. So we took large litters of pups born on the morning of E19 and took a few of those pups every 12 hours for the subsequent 48 hours and analyzed the prevalence of these T cell subtypes in their peripheral blood. Next, we took large litters of pups at each of these time points, took a few of those mice for that same T cell analysis I mentioned, while injecting the remainder of the litter with donor-derived bone marrow cells, looking at the frequency of engraftment, or in other words, the frequency of success of that transplantation in that litter. So what did we find? CD4 single-positive cells here in blue are absent on gestational day 19, but do increase in a near-linear fashion over the preceding or the subsequent 48 hours. Conversely, if you look at the frequency of engraftment or the frequency of success of transplantation over that same interval, it decreases in a stepwise fashion. When you integrate this data, what you find is that when the prevalence of CD4 single-positive T cells exceeds 10%, there is no successful engraftment within that litter, thus defining a threshold of immunocompetence at this point, and suggesting that the acquisition of adaptive immunity is the crucial point determining whether the window is open or closed. Next to our second question, can Tregs expand the window? We studied this in three groups. First, we performed a bone marrow transplant early in gestation on gestational day 14, which our group and others around the country, including Eamon Shaban and T.P. McKenzie's lab, have shown reliably produces engraftment. In our second group, we injected the equivalent dose of cells late in gestation at gestational day 20. And finally, our experimental group here in blue, we enriched the donor bone marrow with donor-derived regulatory T cells. And what we found was this. If you look at the frequency of engraftment in these three groups, first, as predicted, when you inject early in gestation here in white, you see a high frequency of engraftment, about 90%. Again, as predicted, when you inject late in gestation, you see almost no engraftment. But notably and interestingly, when we enriched the allograft with regulatory T cells, we restored the frequency of engraftment to that achieved at the early gestational age time point. And what's more, if you look at the frequency of CD4 single positive T cells in the litters we injected, it far exceeds the threshold of immunocompetence that we previously defined. So what can we conclude from this? First, the emergence of CD4 single positive T cells is a pretty good marker for immunocompetence in the mouse model of IOHCT, suggesting that the acquisition of adaptive T cell immunity is an important trigger. Second, the enrichment of the allograft with Tregs allows engraftment to occur in immunocompetent recipients, thereby extending this window of tolerance to a later point in gestation. And finally, this strategy may help us overcome technical challenges to the clinical application of IOHCT, as well as include fetuses diagnosed after 14 weeks gestation among those eligible for treatment. So thank you very much for listening, and thank you to all the members of our lab who contributed to this work.
We have a few minutes for questions. While people are coming up to the mics, I just wanted to ask quickly if you can give us a couple clinical applicability areas that you guys are going to study.
Yeah. So any disease that's treated postnatally with a bone marrow transplant is theoretically a target disease for IOHCT. The best examples that we frequently cite are sickle cell and beta thalassemia, single gene disorders.
State your name, please.
Decopi, London. Thank you. Great study. Can you elaborate a bit on the implication that have also postnatal therapy?
Yeah.
You're finding?
Yeah, it's a great point. Our model for late gestation IOHCT is in fact a postnatal injection. Yeah. And that's done out of necessity because the acquisition of tolerance occurs after birth in the mouse model as it does not in the dog or the sheep. So part of that's by necessity. Other groups around the country have shown, very importantly, the interconnection between the maternal and fetal immune system, both in T cell trafficking and the transmission of antibodies. So we're not quite sure how the absence of that would have changed the results of our study, but it is an important confounder to consider.
Thank you.
Mm-hmm. Hi, H.B. Kim from Boston. Thank you for that excellent study. I have two questions. First, how did you confirm that the donor inoculum was just regulatory T cells? Were these FOXP3 negative cells? And second, we know that if you also co-inject CD4 positive cells, that you'll get increased engraftment, but it usually is at the expense of getting GVHT later on. So did you see any GVHT in these animals?
It's a great question. Can you pull my slide deck back up, if you can? So the first question I think was about the purity of the Tregs that we injected. So we use magnetic activated cell sorting for CD4 and CD25 co-expression. So in the mouse, that very reliably corresponds to FOXP3 expression. We confirmed that using FOXP3 GFP mice and found our purity to be about 95%. So the markers, at least in the mouse, have pretty high fidelity. But you do bring up a good point. Anytime you inject CD4 positive cells, CD25 can be expressed in activated effector T cells as well. So there is a risk that part of the engraftment we're seeing is because of a graft versus hematopoietic effect. If you look at the end of my talk, if they can bring the slides up, we looked very carefully for this. We looked at whether weight gain was normal, whether they had any phenotypic signs of GVHD like ruffled fur or diarrhea or skin lesions, and we looked at histology to look for hepatocyte necrosis, lymphocyte infiltration, and bile stasis. We saw none of that. So these were phenotypically and histologically normal mice.
Great, thank you.
Thank you.
We're going to now have two tributes. One is to Alex Haller, and the next is to Jim Talbert. Both are videos, and we're going to show them back to back.
I came up just in case I needed to ask for more volume.
I am a country boy from the Appalachian Highlands. I always wanted to be a doctor. Another classmate graduating with me, and I went to Vanderbilt, sight unseen. Our fathers drove us down there. During my undergraduate years, I met and happily subsequently married my wife, Emily Sims. When it came time then to think about going to medical school, I made my decision to come to Hopkins. sight unseen. I'd never even seen the campus. Dr. Blaylock had just come back from Vanderbilt to Hopkins in 1941. I said, I'd like to find out more about pediatric surgery, and I'd like to maybe spend some time at the Boston Children's Hospital. He said, fine. He said, Dr. Gross is a very good friend of mine. And I watched them do some of the earliest pull-through procedures for Hirschsprungs. I got in touch with Dr. Saviston and just wrote a note and said, you won't believe what's going on here. They found that this is due to a lack of ganglion cells in this colon. The first time it's ever been determined. I got a note back and don't believe everything they tell you at Harvard, he said. And so I went through the general surgery program all the way, 5 years. And to make a long story short, they offered me the job to come and be the chief of cardiac surgery at the University of Louisville right out of my residency. So then I get this call from Dr. Blaylock. He said, well, and we'd like you to come back and work with them developing pediatric surgery at Hopkins. So Hopkins won out. I realized that trauma was a major problem, but I didn't realize how significant it was until I began looking at the patients in our intensive care unit. It became increasingly obvious to me that we weren't really focused on a real need of children. Pediatricians kept calling me and saying, I've got a child with a sunken sternum, but I don't know whether it's significant enough to interfere with any physiologic function, and above a certain number, 2.5, were the ones that I operate on. The others I didn't operate on, just because I didn't think they were severe enough and I didn't think they were symptomatic enough. It gives me a chance to repeat what Dr. Blaylock said to me. I've had a wonderful career. You know, I think the greatest satisfaction to me has been the people I've trained and how well they've done and how much they've contributed. That's a living legacy. I like that.
When you were an intern and a junior resident, you know, you were there. Hopkins was a lot of fun because you got to be on call 24 hours a day, 360 days, 355 days a year. Louise Snalfer had trained at Children's in Philadelphia, and she spent a good deal of her time over at Hopkins, Hopkins and the best of CHOP for finished. People thought I just trained at Hopkins and didn't know anything really about pediatric surgery, but actually I got most of what I learned was CHOP. There are better techniques that have come along, some of which were developed here in Florida. We were doing minimally invasive surgery 20 years ahead of the adults. It was just, hey guys, it was a wonderful period. I wouldn't take anything in the world for having been exposed to that period of development of the 50s, the 60s, the 70s, the 80s. I mean, every day it was something new. You were doing something that hadn't been done before, or, you were in the middle of it or helping develop it, and, you were there, you were doing things. It was fun. Well, the whole concept of APSA was to end up getting recognized as a legitimate board of pediatric surgery, get your credentials in pediatric surgery, make that feasible, be recognized nationally as a credible operation. And the first meeting was one that had been picked out to have an initial founders meeting, and that was in Chicago at the Hilton across from the O'Hara Hilton, because everybody could get there, and get out.
Still do that. People still do that.
So, we worked all night practically getting that done. It has matured nicely. It's garnered national and international recognition.
We can invite next to speak Dr. Clara Nicholas. Will be presenting in utero AAV-based genome editing to cure a mouse model of human hereditary tyrosinemia type 1.
Okay. Good morning. My name is Caitlin Van Lith. Thank you for letting me speak today, and I'm going to be presenting in utero gene editing to cure a mouse model of hereditary tyrosinemia type 1. So HT1 is an inborn error of metabolism of the liver in which the gene for fumarate acetoacetate hydrolase, FAH, is mutated. This is the last enzyme in the catabolism of tyrosine. When this enzyme is not functional, there's a buildup of toxic metabolites within the hepatocytes, which leads to fibrosis, cirrhosis, and hepatocellular carcinoma. The current standard of care for this disease is the drug NTBC, which inhibits an earlier enzyme in the pathway. However, there's data to show that patients on adequate NTBC treatment are still developing hepatocellular carcinoma from metabolites that are being released down the pathway. And NTBC is just trading one disease for another. It's trading HT1 for HT3, which still isn't a perfect treatment. So this gave us the idea to use gene editing in order to cure HT1. So in Cas9 gene editing, you guide the Cas9 enzyme to the DNA and create a double-stranded cut at your targeted site, and then the cell repairs it in one of two ways. It either uses non-homologous end joining, in which the cell fills in the gap with random bases and creating random insertions and deletions, and you don't want that. Or it repairs it using homology-directed repair, in which it uses the other DNA strand, or it uses a template that you provide in order to correct the mutation in a way that cures the disease. So this is the goal. So we've done this strategy before in adult mice in ex vivo treatment. So we isolate hepatocytes and we treat them with AAVs carrying the Cas9 and then transplant them back in. When you withdraw mice from NTBC, there's a really strong positive selective advantage for corrected cells. So we cycle the animals on and off of NTBC, and you can see it takes 3 to 4 cycles on NTBC in order to create NTBC independence, which is a sign of phenotypic cure. And then when we do IHC for FAH, we see expansion of those corrected cells. One thing that we're really interested in is enhancing rates of HDR. So typically it's pretty low, usually around 1%. So in this particular study, we used ex vivo culture in order to try to enhance rates of HDR. So the longer we culture them ex vivo, the more they're turning on HDR repair genes and Ki67 expression, which is a cell cycling marker. And those are all things that facilitate an HDR environment. And then that led us to the hypothesis of what environment is more highly expressing DNA repair genes, cell cycling genes than the fetal environment. So on top of those reasons, we also are using in utero gene editing because of the rapid expansion of fetal hepatocytes. It's an immune-privileged environment, and we can mitigate early organ damage of NTBC, or of HT1. So these are 2 AAV vectors. One is carrying the Cas9 enzyme, and one is carrying a 1.2 kb homology template, which is the DNA that is going to correct the mutation for HT1. We do a direct fetal hepatic injection at E15 out of about 21 of the 2 AAV vectors, and then at the time of weaning, we withdraw the animals from NTBC. When we use an AAV that's carrying GFP, we see near complete targeting of fetal hepatocytes when injected at E15, suggesting that there's really good targeting in this fetal environment. We then moved on to do this in 10 mice, following 5 of them long-term. 3 out of these 5 mice required no NTBC after time of weaning, which, if you remember back to our ex vivo strategy, those required 3 to 4 cycles on NTBC. This is suggesting that the mice were essentially cured at birth of their disease. And then 2 of our mice required 1 cycle of NTBC. When we look at FAH-IHC, you see over time there's an expansion of FAH-positive hepatocytes from pre-weaning, so this is basically at birth, up to 49 days where you see near complete repopulation of the liver with FAH-positive hepatocytes. We also see biochemical cure. Tyrosine, which is the marker for H2-1, is normalized to wild-type levels in our treated mice, and other liver function enzymes are also normalized to wild-type levels at 2 months post-weaning. We then did a genetic profile of these hepatocytes, and we saw about 5% rates of perfect HDR. So as I mentioned earlier, typical is around 1 to 2%, suggesting that the fetal environment really does increase these rates. We also saw minimal presence of any potential off-target events. And our target sequence was the second most common sequence found after wild-type sequence. So in conclusion, we used in utero AAV-based gene editing in order to cure a mouse model of H2-1, and the cure occurs early with little or no cycling of NTBC. So I'd like to thank Dr. Clara Nicholas and Dr. Joseph Villegard for helping with a lot of this work and performing a lot of this work, and then the others in our lab who were there to support us. Thank you.
I apologize, Caitlin, for
that's okay.
So, if there's any questions, we have 2 minutes. Do you, again, similar to the first speaker, are there other disease processes that you're planning on studying using these methods?
So we're starting to look into PKU. The most common mutation in humans is a single base mutation, and so this could potentially be used in that situation as well.
Thank you. Please state your name.
Donahoe, Boston. Excellent presentation, and I think this approach is absolutely going to change the field of pediatric surgery and what we can do as surgeons. It is a Nobel Prize approach, and you guys have made tremendous advances here. Very, very excellent use of homologous recombination. The question is, will you get better recombination in utero than you would postnatally? In other words, is the turnover more rapid, and is there advantage to doing that because you're obviously introducing a risk?
So we haven't compared it to immediately postnatal mice, but when we compare it to adult mice, that's definitely much higher rates.
Thank you.
Question?
Thanks. David Hackman from Johns Hopkins. That was just beautiful. Beautiful science, beautifully presented, and really clear. 2 questions. First, in relation to Dr. Donahoe's question, when you deliver the AAV in utero, as compared to the postnatal event, there's so many additional developmental pathways that are still turned on that are, of course, are then not turned on in the postnatal life cycle. And so I'm wondering whether you may not necessarily see off-target effects, but unintended effects because of the potential overlap between important pathways, especially metabolic pathways. And secondly, tell us a little bit about durability of the effect. Most of the work seemed to be ex vivo, in terms of persistence and cell cycle turnover, et cetera. And I'm just wondering how persistent these effects are. Again, beautiful work.
Thank you. And so we haven't looked specifically at other pathways in our mice, except they were phenotypically normal throughout their lifetime, suggesting that there probably weren't any major metabolic disturbances because of the procedure. Can you repeat your second? Just remind me what your second. Persistence. We're looking into how these different HDR DNA repair genes, Ki67, are actually expressed in utero, and we know that those naturally fall off over the course of the lifetime of the mouse because Adult hepatocytes are essentially quiescent, so they don't have DNA repair as well as other cells. They don't have Ki67 expression.
Great, thank you.
Thank you.
Thank you very much. Our next presentation will be minimizing variance in pediatric surgical care through implementation of a colon bundle, a multi-institution study. Presenter will be Aaron J. Cunningham.
Thank you for the opportunity to present our work. We have no disclosures. Standardization associated with enhanced recovery after surgery, or ERAS protocols, have produced significant gains in adult surgical outcomes. This is actually the other presentation.
Can we get S62?
I could give that one if. Better. Okay. Thank you again. We still don't have any disclosures. So, standardization associated with enhanced recovery after surgery, or ERAS protocols, have produced significant gains in adult surgical outcomes, including notable reductions in surgical site infections after colorectal surgery. However, there has been little evidence to date demonstrating similar gains in children. As part of an ongoing initiative to minimize variance in pediatric surgical care and reduce SSI, we developed a standard perioperative colon bundle in an effort to affect postoperative morbidity, cost, and resource utilization. The purpose of this study is to investigate the impact of that protocol, and we hypothesized that the introduction of a perioperative colon bundle can reduce SSI. In December 2014, the pediatric colon bundle was adopted from a larger adult initiative and modified to reflect the unique concerns present in the care of children. The bundle consists of recommendations for all phases of care, including pre, intra, and postoperative management. Some of the highlights of our bundle include standardized pre- and intraoperative skin preparation, along with standard antibiotics. Intraoperatively, gloves and surgical instruments were exchanged prior to skin closure. And in cases where the wound was grossly contaminated, superficial drains were left in the subcutaneous tissue until the first dressing change. To study the efficacy of this bundle, we performed a retrospective review of all children who underwent colorectal procedures within 1.5 years of protocol implementation. Surgical site infections were defined according to NISQIP definitions, and compliance required documentation of at least half of the 8 surgical components, including at least one of the intraoperative components of the bundle. Children whose wound were not closed during the index procedure and those who underwent isolated anal procedures were excluded from analysis. 168 colorectal procedures took place during the study period. Ultimately, 24 were excluded. Of the 144 procedures analyzed, 67 occurred prior to protocol implementation and 77 occurred after. Median age for our population was 6 years and 51% were female. The most common preoperative diagnoses were threatened bowel and benign colon disease, which is an inclusive diagnostic category used to refer to functional indications for colorectal procedures, including prior diversion or neurogenic bowel. The majority of procedures were open colectomy, laparoscopic colectomy, and colostomy closure. And if you look here on the right, you can see that age, sex, diagnosis, and procedure were similar before and after protocol implementation. Overall outcomes are shown here. Notably, more than 1 in 10 patients in our study developed SSI, 10% were readmitted, and 10% required reoperation. Following protocol implementation, the incidence of superficial site infection decreased by 11%, and readmission decreased by 12%, while length of stay, cost, other infectious complications, and reoperations were not significantly different. Lastly, in an analysis of secondary outcomes, we found that antibiotic durations beyond 48 hours postoperatively decreased by 13% after introduction of the perioperative protocol. To summarize, we found that implementation of a perioperative colon bundle can significantly reduce surgical site infections without increasing length of stay or hospital cost. Protocol introduction was also associated with an increase in antibiotic stewardship and a significant decrease in the number of patients receiving long-course antibiotics. Moving forward, large studies and regional research consortiums are needed to evaluate the efficacy of pediatric colon bundles in standard surgical practice. Thank you.
Very nice. This paper is now open for questions. I have a question. So it's actually 3 parts. So first off, whenever you do these things, you sort of have a Hawthorne effect where you do a study and you see the effects. So that's one question. The second is sustainability, and the third is generalization. So can you address those?
I would definitely agree. There's certainly some component of a Hawthorne effect that's ongoing here, especially since in the setting of our overall project to minimize variance in pediatric surgical care. So the colon bundle was just one of many protocols that have gone out, and so there's been an increase in compliance, which kind of streamlines everyone, and that results in some significant gains. Your second question was durability. Certainly, especially with any quality improvement project, durability is something that's of concern. We have interval data that will be collected shortly, but there was initial push in decrease in surgical site infections, and some of that is slowly starting to creep up. So just as the group from Columbus yesterday presented on their second look at their broader GI bundle, which was presented here a few years ago, and they were able to bring down the SSIs by kind of reinvigorating. We plan to do the same. And then the third, broader applicability. Certainly, I would like to comment on the whole process, because I think that's what resulted in our significant gains, reviewing the literature, coming up with a bundle that everyone agreed on, and then implementing that. So I think that process overall is applicable to everyone.
Question?
Yeah, thank you very much. Oscar Gomez from Spain. Thank you, doctor, for presenting us your protocol. Do you have any specific management in your protocol for preoperative IP fluid for babies, as well as how to treat dehydration due to the protocol?
Thank you. That's very interesting. We have not specifically looked at postoperative fluid resuscitation or standardized that management, but I think certainly that's an area of great interest.
Is this on the APSA website under the toolkit section?
It will be.
Awesome. Thanks. All right, we'll invite the next speaker to the stage. So the next talk is Pediatric Trauma Venous Thromboembolism Prediction Algorithm outperforms current anticoagulation prophylaxis guidelines, a multi-center pilot study, presented by J Cunningham.
Do you want me to talk again? Okay. Okay, well, it's good to be back. Thank you again, and we're really excited to share this with the APSA community. We have no disclosures. Venous thromboembolism is a rare but prevalent problem in pediatric trauma, affecting as much as 6% of all critically injured children. Morbid sequelae from these events can be substantial, with 20% of children developing post-thrombotic syndrome or pulmonary embolus, resulting in up to 9% mortality. Unfortunately, robust data on the prevention and management of VTE in pediatric trauma has been generally lacking. To date, the best available evidence is represented in a clinical consensus guideline written by PTS and EAST in 2017. Unfortunately, due to the limitations of the available evidence, these recommendations provide incomplete guidance to the pediatric trauma surgeon regarding best practices for VTE prevention. To address these heterogeneities, our group developed an algorithm to predict VTE in pediatric trauma. And the purpose of this study was to externally validate that algorithm in a retrospective data set and to compare the effectiveness of our algorithm against current recommendations. The VTE prediction algorithm was derived from a retrospective analysis of the National Trauma Data Bank from 2007 to 2012 and was previously published. The analysis looked at over 500,000 pediatric trauma patients and created a risk score from 10 clinical variables to assign a predicted risk of subsequent VTE, as seen here. To externally validate this algorithm, we performed a retrospective review of 2 institutional trauma registries from 2007 to 2018. All pediatric trauma patients in the registry were included in this study. VTE risk was categorized as low, moderate, or high risk for less than 1, 1 to 5, and greater than 5% predicted risk, respectively. Comparison of the prediction algorithm to current guidelines was performed in an intention-to-treat fashion. Over 11.5 years, 8,271 pediatric trauma patients were included in the registry. Of those, 31 were diagnosed with VTE, which was 0.37%. This included 28 patients with DVT only, 2 patients with PE only, and 1 patient with both DVT and PE. Oh, can we go back? I'll move forward. Looking at those who developed DVT or VTE and those who didn't, we see that with the exception of sex, each of the clinical variables in the prediction algorithm was significantly greater in those who developed VTE. Using those variables, a VTE risk score was calculated. Plotting that score against the outcome of VTE on a receiver operating characteristic curve, as seen here on the right, we note a strong discriminatory ability of our algorithm to identify those with VTE with an area under the curve of 0.933. Next, we compare the diagnostic statistics of the VTE prediction algorithm against current PTS East recommendations, noting better sensitivity, specificity, positive and negative predictive value with lower false positive and false negative rates. Importantly, the VTE prediction algorithm outperforms current recommendations while also anticoagulating only 1/4 of those children that would receive blood thinners under current guidelines. In our population, prospective application of PTS East guidelines would result in 1,935 children receiving pharmacologic prophylaxis, while use of the VTE prediction algorithm would only anticoagulate 373 children. To summarize, we demonstrate that a VTE prediction algorithm with 10 clinical variables can accurately discriminate between children who would and would not develop VTE in a pilot population. Additionally, use of this algorithm outperforms current recommendations while anticoagulating 19% fewer children. Given the limited size of our sample, larger retrospective multi-center studies are needed to confirm the results of this pilot study prior to prospective implementation. And we are currently enrolling sites in such a study as sponsored by PTS. If there's any interest, please contact us through this email or you can talk to me directly. Thank you.
We're open for questions.
So I have a question. Does you know, the incidence of VTE is so small, and so doing randomized control trials or whatever, you know, the N is so high. So will this, you know, and then if you look at those in the ICU, then you're starting to get a little greater number. Mm-hmm. And in terms of your predictive scores, is that going to help you with a study to be able to get to a point where you can actually do the study?
So certainly that's why just this data set alone, even 8,000 patients, isn't quite enough to truly validate our model. It has 10 clinical variables, so we suspect we need at least 100 cases of VTE in order to accurately do that. That's why we're looking more at the multi-center study. If we look just at children who are in the ICU, I think we miss out on a valuable opportunity to kind of catch everyone. Certainly that might help us boost our numbers, but I think overall, if you look in our population, only about a third made it to the ICU, so now we're kind of dwindling down what our population would be, and we need more centers, arguably. But certainly, multi-center studies are needed to even look at this.
Thank you. Okay, so the next presenter is Kate Savoy. The talk is Decreasing Postoperative Complications in Surgically Placed Gastrostomy Tubes, a Quality Improvement Initiative. Use the clicker or the mouse.
Okay, I'm going to use the mouse. Thank you for the opportunity to present our work today. We have no disclosures. Gastrostomy tubes are one of the most common operations performed by pediatric surgeons. Within the surgical literature, there is a highly variable rate of complications that's been reported. And after reviewing our own institutional outcomes, we felt that our complication rate was higher than anticipated, and we found that patients that had a complication had an increased length of stay of 4 weeks. With this in mind, a multidisciplinary team was formed as part of a quality improvement initiative to determine ways to decrease our complications in our neonatal population. We defined complications as dislodgement, leakage, erosion, cellulitis, and infection. Our specific aim was to decrease our complication rate to 25% within 1 year and maintain that change for 1 year. Our key driver diagram had 4 primary drivers, and this study specifically focused on our efforts to standardize gastrostomy tube wound care and feeding practices. We standardized the dressings for both low profile and standard G tubes to provide stabilization and to prevent traction on the tube. These dressings were changed daily for the first 7 days postoperatively by a neonatal nurse practitioner or wound care ostomy nurse. This allowed for ongoing assessment of the site. Patients were then categorized into 3 groups based on whether they had never achieved full feeds, whether they were tolerating full continuous feeds, or whether they had achieved full bolus feeds preoperatively. Group A patients were advanced on a separate institutional guideline. However, Group B and C patients were advanced based on their preoperative feeding status. An identification card was then placed at bedside to help relay critical information to the care team. This included information regarding the dressing changes and the feeding group. This is a run chart. It allows us to track our complications over time. So the green line is going to be our goal, and the blue dashed line represents our complication for that process stage. The red line is going to be our confidence interval. This is going to change on a month-to-month basis based on how many cases are performed each month. At baseline, we had a complication rate of 37%. After implementation of our QI initiative, we were able to decrease our complication rate to 22%, thus meeting and exceeding our goal within the first 8 months of our initiative. A PDSA cycle was then performed, and this resulted in modifications to the dressing change technique, the providers changing the dressing, and had increased feeding guidelines compliance. After implementation of this PDSA, we were able to further decrease our complication rate to 6% for an overall reduction of 84%. This rate has been maintained for over a year. Our balancing measure was length of stay after placement of gastrostomy tubes. Although patients were on full calories by postoperative day 2, we kept them on continuous feeds until postoperative day 7. This was intentionally done to allow us to separate complications related to the wound care from those related to the feeding practices. Since reaching our lowest complication rate, 2 additional PDSA cycles have been performed and allowed us to systematically decrease our time to full bolus feed without an increase in our rate of complications. If a patient was on full feeds preoperatively, they are now advanced to full bolus tube feeds within a week. In conclusion, we were able to reduce our complications from gastrostomy tube placement from 37% to 6% by standardizing our gastrostomy tube dressing, our postoperative wound care, and our feeding practice guidelines. Additionally, further PDSAs have allowed us to improve our balancing measure of length of stay. With that, I will conclude and open the floor to questions.
Cynthia Reyes, Orlando. That's a beautiful study on how a quality initiative could improve the care of patients. I commend you on a job well done.
Thank you.
So our reps from the G-tube companies tell us that when we have G-tube problems and complications like this, it's usually related to the length, the size of the tube. And we started paying more attention to the size of the tube, carefully measuring the length of the track in the operating room, giving a little bit of slack with the anticipation that the child's going to grow and we'll need a longer tube fairly quickly, and being more aggressive to change the length of the tube in the clinic when we see that problems are starting, and we've been able to decrease our problems that way. Does your protocol involve that process, changing the tubes, measuring the length in the operating room? Did that affect your results?
With regards to the size of the tube, that's left up to the discretion of the operating surgeon. However, they are measured intraoperatively to provide the appropriate length between the balloon and the bolster. And then we have a systematic way of changing the tubes in an outpatient setting.
Question in the middle.
John Raffensperger. The babies who require gastrostomy are also the ones who are most likely to develop gastroesophageal reflux. The placement of the tube on the stomach is most important. If you put it on the greater curvature and pull down the greater curvature a little bit, you will decrease the angle of hiss. If you put it on the lesser curvature with a little traction, you'll increase the angle of hiss and go a long ways towards preventing GE reflux. The first Nissen operation for the prevention of GE reflux was simply to stabilize and traction on the lesser curvature. So be very careful where you put the tube.
Thank you, sir. Thank you.
Okay, so this year we were very pleased to invite our Grossfeld Foundation scholar to present his work during this plenary session. You can come up, Amar. So since its inception in 1991, donations to the foundation have exceeded more than $1 million, and it's provided more than $560,000 in grant support for our young pediatric surgeon scientists, the majority of whom have used their enrichment dollars as a springboard to acquire external funding from the NIH and other sources. Donations can be made on the APSA website. Please join me in welcoming Amar Nijagal from the University of California, San Francisco, who will be speaking on fetal mechanisms of liver and bile duct repair, a link to the prenatal origins of biliary atresia.
Good morning, and thank you. I'd like to thank the APSA Foundation for this award and for its support as I embark on my career as a surgeon scientist. When my fellowship was over, I spent some time delineating my research focus, and although I was intrigued by the work I had completed as a postdoctoral fellow on immune responses to stem cell transplantation, I've been fascinated by how the immune system may regulate fetal liver development and perinatal liver repair. The developing liver is an interesting organ where several biological processes are occurring simultaneously. As development progresses, the fetal liver is relinquishing its role as the primary hematopoietic organ. What interests me is this critical and unique perinatal window when the developing immune system and the developing liver coexist. My research is focused on how the immune system regulates liver development and how the immune system participates in the resolution of perinatal liver inflammation. And it didn't take me long to figure out how the investigation of these basic biological processes may relate to human disease, as it immediately made me think critically of biliary atresia. This photograph was taken in the operating room of a diseased liver in a patient with biliary atresia, showing the skeletonized portal triad after the obliterated and fibrotic bile ducts have been excised. What is fascinating about this disease is that the rapidly progressive nature of biliary atresia suggests that the mechanisms responsible for restoring tissue homeostasis following inflammation are impaired in affected infants. We have been studying the role of the immune system on the resolution of perinatal inflammation, and our preliminary experiments have led us to focus on the innate immune system, and specifically monocytes. Monocytes are important for inflammation after tissue injury and also resolution of injury. These cells are thought to transition from a pro-inflammatory state to a pro-reparative state at sites of inflammation. And monocyte subsets can be distinguished by the expression of several cell surface markers, including Ly6C. Pro-inflammatory or classical monocytes are Ly6C high, and I will refer to them as CMOS. And pro-reparative or non-classical monocytes are Ly6C low, and I will refer to them as NMOS. Our research has focused on the function of monocytes and their contribution to the pathogenesis and resolution of perinatal hepatic inflammation. In order to understand the role of monocyte subsets during perinatal liver inflammation, we first characterized the relative proportion of each cell type in a non-inflamed setting. We harvested livers from late gestation fetuses and neonatal pups and used flow cytometry to quantify NMOS and CMOS. And what we found was that the reparative NMOS outnumber CMOS by over 2,000-fold in the late gestation fetus. This was in a healthy, non-inflamed animal. In order to understand the role of these monocyte subsets during inflammation, we used an infectious model of perinatal liver inflammation. When neonatal pups are injected with rhesus rotavirus within the first 48 hours of life, they develop severe periportal inflammation, and the majority of these pups die by 21 days. Using fetal surgical techniques, we adapted this model to the fetal environment and injected RV into mid-gestation fetuses and found they are resistant to RV-mediated disease. But interestingly, we observed an association between the relative abundance of the reparative NMOS and the susceptibility to disease. In neonatal pups, where the ratio of NMOS to CMOS is close to 1, these animals are susceptible. And in the late gestation fetus, when NMOS outnumber CMOS, these animals are resistant. These results suggested that the abundance of NMOS was associated with the resolution of perinatal liver inflammation, and we further dissected the role of these reparative NMOS in the postnatal setting by specifically ablating pro-inflammatory populations. And we quantified neutrophils, CMOS, and NMOS in one of 5 settings. The first setting over here is in the non-inflamed healthy liver. The second setting is with RV infection alone. And the third is after depletion of neutrophils using an antibody called anti-Ly6G. The fourth is the depletion of monocytes, specifically CMOS, with the administration of anti-CCR2. And the fifth is when both neutrophils and CMOS are depleted. And we observe some expected results. So for example, when we give animals anti-Ly6G, we effectively deplete neutrophils. When we give animals anti-CCR2, we effectively deplete CMOS. When we give animals both neutrophils and anti-CCR2, we deplete neutrophils and CMOS, but we also notice this expansion of the reparative NMOS population, suggesting an interplay between these cell types. But said slightly differently, what we were able to do experimentally is replicate the fetal environment and the abundance of NMOS relative to pro-inflammatory populations. And one would predict that if the abundance of NMOS is associated with resolution of perinatal liver inflammation, we would expect that animals survive in this condition when NMOS are allowed to expand. And this is exactly what we saw. So when we administer RV alone, shown here in black, these animals die by 21 days. When we give either antibody to deplete CMOS or antibody to deplete neutrophils, we actually hasten their death, likely related to the compensatory function between these two cell types. However, when we deplete both of these cell types, we see that these animals survive. In summary, we've made the observation that the abundance of NMOS in 3 different settings correlates with susceptibility to disease. In the late gestation fetus, we observe resistance to disease when NMOS are abundant. In postnatal animals, we have noticed susceptibility to disease when pro-inflammatory CMOS outnumber NMOS. And experimentally, we have been able to replicate the fetal environment by depleting these pro-inflammatory populations and thereby rendering animals resistant to disease, likely as a result of the expansion of pro-reparative NMOS. This has led to our current working hypothesis that the naturally occurring abundance of NMOS renders fetuses protected from inflammation, and that changes in these monocyte subsets may account for susceptibility to diseases like biliary atresia. I'd like to thank my lab as well as my clinical partners for providing me the time to do this work as well as for my funding sources. I'd be happy to take questions.
We have time for one quick question if anyone has any questions, but I do want to get an update on how this has led to more possible funding sources for you.
Yeah, the APSA award has really provided a kickstart for my lab. So we were fortunate enough to get an ACS award this year, as well as a UCSF Liver Center award that has external hepatologists that review our grants, and I've submitted my K award.
That's exciting. Question?
Yes, I Swan Holterman, University of Illinois. I'd like to congratulate you for a novel way to look at pathophysiology of biliary atresia. My question has to do with your model. With the RV model, you assume that the pathogenesis of biliary atresia is viral in nature. And of course, when you have a viral infection, you do skew your immune response to a certain type of subset of inflammatory or pro-inflammatory cells. So that's my question. So then to follow up on that, I guess, are there other models that you can use that doesn't rely so much on viral infection? And one thing I can think of, for instance, are the MDR knockout mice, that really do not have a viral basis to the model. And actually, I don't think anybody has quite looked at the fetal environment in those knockout mice.
Thank you for that question as well as the suggestion. I completely agree with you. The way in which we've used this viral infection model is, it's not, in my mind, it's not a model of biliary atresia, but it's a means to induce perinatal liver inflammation. But I completely agree that the infectious aspect of the model really complicates the interpretation of the results. And one thing that we are working towards in the lab is an actual sterile model of liver injury using thermal energy, for example, to induce specific necrosis. Now, I haven't characterized these monocyte subsets in that setting, but I agree with you long term, we will have to figure out some alternative models to study this pathophysiology.
Thank you.
Thanks.
Our next presentation is going to be sexual function and fertility in females after surgery for Hirschsprung's disease. It'll be delivered by Joseph R. Davidson.
Good morning, and thank you for the opportunity to present the work. We have no disclosures to make. So there's a growing awareness of an issue of subfertility in women following ileoanal pouch surgery for ulcerative colitis and FAP, and it's also been suggested that these women are at an increased risk of miscarriage and recurrent miscarriages. And so our study aim was to look in a large adult follow-up cohort from our center at the effects of pull-through surgery on fertility and sexual function in women who've been treated for Hirschsprung's. This was a national ethics-approved study, and we included all women who received primary or redo pull-through surgery for Hirschsprung's disease from 1978. We excluded any women with intellectual impairment and any who had left the country or who had absent contact information according to the NHS spine. We analyzed clinical data, and potential participants were invited to complete functional and quality of life questionnaires, which included bowel function, GI quality of life and general quality of life, and the sexual quality of life for female questionnaire, which I will explain a bit later. Just to have a bit of a look about this cohort in terms of their surgical outcomes, about 2/3 of these women had short segment disease, and we're using a very similar analogy of what long segment disease and TCA, totocolonic and totocolonic with extension into the small bowel, as was described yesterday by the systematic review. Perhaps unfamiliar to most surgeons here, the majority of these women were having Duhamel pull-throughs. And the complication rates displayed here, there's a redo pull-through rate of 18% within our own cohort, but most of these were not for transition zone pull-throughs, but were for non-functioning ganglionic pull-throughs. We had 3 women included within our cohort who were referred in from other centers for redo surgery. And our definition of enterocolitis is a combination of clinician and patient-reported episodes. So we identified 59 eligible women, and we had to exclude 8 of them. And our response rate from the 51 women who were approached was 78%. The median age was 29. About half of these women were in a stable relationship. 93% of them had been sexually active at a median coital debut of 17 years. And 18 of 37, so 49% of these women were reporting frequent or dyspareunia every single time they had intercourse. And we're going to look here at the SQUAL-F, the Sexual Quality of Life in Females questionnaire. Now, this is a questionnaire that's been developed largely on the psychosocial aspects of sexual quality of life. You can see here there's a huge spread, and we've got a control population from when this questionnaire was designed. And if we look at the mean of our population compared to a mean from the normal population, there's a clear discrepancy. But it's this tail which is quite concerning. We're seeing that 8 of the 37 women who completed it were 2 standard deviations or more below the mean. And we looked at things that might be associated with this, and we saw that there was a significant correlation between bowel function and sexual quality of life, and GI quality of life and sexual quality of life. And when we looked at subdomains, obviously these are all interrelated, so performing a multivariate logistic regression wouldn't show an independent factor, but every single one of the subdomains in quality of life seemed to affect your sexual quality of life. We wanted to know a bit more about fertility in these women. 16 of them had attempted to become pregnant, and 7 had been able to achieve spontaneous pregnancies. However, just under half of these women had multiple miscarriages. And this gives us a rate of about 56% within our population who are unable to achieve a spontaneous pregnancy. And this reflects the data that's been shown in adults after pouch surgery for ulcerative colitis, that the rates can go up to about 50% for women who are unable to get pregnant without assisted fertility. The 9 remaining women were referred for fertility investigation and therapy. 3 had been able to become successfully pregnant with IVF. 3 had ongoing treatment, and 3 had unfortunately failed. So in summary, ladies and gentlemen, we believe that when women's sexual quality of life correlates to bowel function outcomes and GI quality of life after surgery for Hirschsprung's, our results would suggest that there is an unrecognized burden of subfertility in these women. And we believe that sensitive discussions of sexual issues and fertility should be included in transition clinic appointments for these women. Thank you very much for your time, and I welcome any questions.
This paper is now open for questions.
Diana Farmer from Sacramento. I just want to congratulate the authors on this really important work, and I think that this is one of the sort of important activities for pediatric surgeons, and as we mature as an organization, and more importantly as our patients mature, that looking carefully at these long-term options which outcomes which tend to fall through the cracks because we turn our patients over to our adult colleagues. So developing these relationships with our adult colleagues so that we can answer these questions is really important. My question for you is, what do you think the mechanism of action here is that is resulting in these sort of disturbing findings that you are seeing? What's causing the issues around dyspareunia, do you think? It's hard for me to put that together. And fertility, I think, is a little more logical. I'm guessing that the presumption that that's some inflammatory response to particularly the operations, which in the early days were likely all open procedures. So it would be interesting to see in the future whether we can connect that to changes in surgical techniques. Thank you very much for this great work.
Thank you, Dr. Farmer. I think that there's a few things to unpick. I think we know from looking at populations of patients with anorectal malformation that in females specifically, your sexual quality of life is intimately related to your continence. And so women who have a poor bowel function score tended to have a lower sexual quality of life. And I think that's been shown with other conditions, and there's no reason to suggest it wouldn't be the case in Hirschsprung's. I think in terms of the mechanisms behind the infertility, anecdotally, this is tubal infertility. This is related to adhesions of the fallopian tubes. And this is, again, what's been demonstrated in the pouch surgery cohort, that there's a problem, a mechanical problem with the tubes rather than a problem with the egg, so to speak. I think it's really interesting to think about potentially the advent of novel techniques, and I would really welcome anyone to collaborate in looking at comparative cohorts of patients who've had laparoscopic assisted pull-throughs or transanal operations. I think the group from the Mayo Clinic described that their laparoscopic pouches all were able to get successfully pregnant. So that's potentially an advantage in the case of pull-throughs. It doesn't really seem that there's been much of a discrepancy between the outcomes we're reporting in terms of bowel function and other techniques, but this might be something that does set them apart.
Thank you very much. We're going to have to move along because of time.
Thank you.
Our last presentation of the session is ultrasound-guided epigastric hernia repair, presented by Mercedes Pilkington from Michigan.
Using only a silk tie and a meniscus needle, it is performed under direct visualization using a 20 MHz linear high-frequency transducer. First, the surgeon performs a diagnostic ultrasound to localize the hernia defect and manually reduces the incarcerated preperitoneal fat. The hernia is demonstrated here. Next, under direct ultrasound guidance, the meniscus needle is passed transfascially in a caudal to cranial direction. The needle is seen as bright white as it passes through the fascia and travels just above the preperitoneal fat before it is brought out through the skin superior to the defect. Suction is used to help feed the O-silk tie through the meniscus needle, which is then removed, leaving only the tie in place. The needle is then passed a second time. Using the same entry and exit points in the skin, this time it is passed through the subcutaneous tissue, just superior to the fascia, again under direct ultrasound guidance. The cranial end of the previously placed silk is then fed with suction through the meniscus needle. Both ends of the tie are now exiting together, and the suture loop is carefully pulled tight. The skin is pulled free to avoid puckering. Ultrasound verifies that the hernia defect has been closed. Finally, the suture is tied down and cut. The skin was closed with glue and the patient discharged home. To date, we have attempted 18 ultrasound-guided epigastric hernia repairs in 17 patients at our institution since January 2018. One required conversion to an open procedure due to difficulty reducing the hernia contents, while all others were completed with the technique demonstrated. Our median operating time has been 28 minutes, which includes the surgeon-performed diagnostic ultrasound and repair. Few patients were seen in follow-up clinic, but the median interval from surgery is 6.2 months. To date, there have been 3 complications. One patient developed a superficial site infection that resolved with oral antibiotics. A second patient had persistent inflammation at the stitch exit site, and a third had a recurrence of the hernia in face of a sterile stitch abscess due to the silk suture, and underwent a subsequent open repair after 3 months. Modifications have included using a Vicro stitch to reduce the foreign body reaction, and larger transfascial bites to better secure the repair. The patient's abdomen is demonstrated at the 2-week follow-up visit.
We're open for discussion. So, Mercedes, this is an exciting application of image-guided surgery. I wonder if you can comment, or if your authors can comment, if he's here, on what kind of training and what kind of preparation is necessary to perform this type of image-guided surgery. How much experience do you think you need before you can embark on this kind of a procedure?
Yeah, I think that's a great question, and you get to a very important point. Absolutely, additional training is necessary to be facile with ultrasound and to perform procedures like this with ultrasound. we're lucky at our institution to have a pediatric surgeon who has additional formal training in radiology, and certainly that allows us to push the envelope with this. But I think the skills necessary to perform tasks like this with advanced ultrasound are certainly within reach of all pediatric surgeons, but certainly additional training is required, whether that be mentorship with someone who already has those skills or through simulation training. I don't think everyone needs to do an interventional radiology fellowship to get these skills, but certainly some additional training is required to be able to confidently perform this. It looks easy in Dr. Jarbo's hands, but as we all know, ultrasound can be a fickle thing.
Question?
Cynthia, Reyes again. So this is a novel technique. Do you anticipate the interventional radiologist stealing this operation from us like all the other cases that we've lost to them?
Thanks for that question. It hasn't been a concern that we've discussed to date. I suppose there is always that risk that they could come into our realm, but it hasn't been a concern just yet.
Can I make a comment?
Of course.
Yeah, that is that I believe that especially if I were a young pediatric surgeon and I were seeing this, I would understand that it would almost be mandated that I become excellent at these types of techniques using ultrasound so that, per Dr. Reyes' comment, this stays in the domain of pediatric surgery.
Okay. I saw on Holterman, University of Illinois. So this speaks to the skill of the sonographer, because oftentimes, the defect in the fascia is very small. It can be as small as 1 millimeter, and sometimes it's difficult to reduce the epigastric, the preperineal fat because of that. So do you have some sort of patient selection? And I don't know how sensitive ultrasound is to detecting these subset of patients.
We don't have any specific criteria used to identify the patients to date. The way this actually evolved is initially, as probably everyone knows, occasionally you're in those positions where you're doing an open epigastric hernia repair and it's challenging to find what can be as you say, 1 to 2 millimeter defect. And so that's where we really brought ultrasound in initially to see if we could help to locate those, and found that we were able to do so. I think we did 18 repairs, but there's been closer to 25 patients in whom we've more formally looked for their epigastric hernia using ultrasound. And there were 2 in whom we weren't able to confirm with the skin closed. The case had already begun, but through the incision we were able to identify them, but we didn't formally look at the sensitivity of ultrasound.
I wanted to follow up with that because I'm Marcus Jarbo from Michigan. That clip you saw, that hernia defect was about 1 millimeter size. So I haven't ever seen an epigastric hernia that I couldn't see. It's pretty easy to see. Does that make sense? If you see it on clinically, you can see it with ultrasound.
Marcus, real quick, can you tell them what your training is?
Sorry, I was a fully trained pediatric surgeon, with the whole 9 yards. And then Ron convinced me to do an IR fellowship after my pediatric surgery fellowship. So I did a full year of adult interventional radiology with a little pediatric interventional radiology thrown into that. And so that was in 2010. So I do 1 day of interventional radiology where I'm the interventional radiologist at Mott Children's Hospital, and the other 6 days a week, I'm a surgeon.
We're going to take a last question here in the center.
All right. So my question kind of follows up on Dr. Holterman's is the other end of the spectrum. Are there defects that are bigger that you would think about putting in multiple stitches as opposed to a single stitch? And have you ever run into breaking the stitch and having to replace it again?
Thanks for your questions. Yes to both. On occasion, there are larger defects which require more than 1 suture. And initially, when we were using a smaller caliber suture, there were some stitch breakages, and that's what led to us using the O silk or O vicryl at this time.